Good morning. Today's topic is calculus and iatrogenic factors in periodontal disease. Calculus consists of mineralized bacterial plaque that forms on the surface of natural teeth and dental prosthesis. It is one of the predisposing factor of gingival inflammation. Presence of plaque is necessary for the formation of calculus, as it is the mineralized form of plaque. Now, types of plaque are supragingival calculus and subgingival calculus depending on the location of the calculus. So, as the name indicates, supragingival calculus it is present coronal to the gingival margin, whereas subgingival calculus is present below the gingival margin. Supragingival calculus is white to whitish yellow and it is hard with clay-like consistency, and it is easily detachable from the tooth surface. Whereas subgingival calculus is dark brown or greenish black in color. It is hard, dense and firmly adheres to the tooth surface and it cannot be easily removed. Supragingival calculus may contain both supra as well as subgingival calculus. It consists of brushite and octacalcium phosphate, whereas subgingival calculus consists of hydroxyapatite and magnesium. In case of formation of supragingival calculus, there is an important role of saliva, whereas in the formation of subgingival calculus, there is role of GCF. In the supragingival calculus, the calcium phosphate ratio is low, whereas in subgingival it is increased. This is diagrammatic representation of supra and subgingival calculus. As you can appreciate in the first picture that along the coronal, along the gingival marginal plaque calculus is present. This is supragingival calculus, and subgingival calculus is not evident in this picture as it is present below the margin of the gingiva. So, with the help of probe, you can locate the subgingival calculus. Now, coming to composition of the calculus, it consists of organic and inorganic components. The inorganic components are calcium phosphate, calcium carbonate, magnesium phosphate, and these are the other elements which are present like sodium, zinc, strontium, copper, aluminium, gold. Now, the organic components are protein polysaccharide complexes, desquamated epithelial cells, leukocytes and microorganisms, and the crystal form is composed of brushite, hydroxyapatite, magnesium, octacalcium phosphate. Now, calculus and radiograph. Calculus can be seen radiographically also. As you can see in this picture, mesial and distal to the molar, lower molar, there is calculus or tartar under the gums, but it is not that you can radiograph is the confirmatory diagnosis for the calculus. You have to check for the calculus clinically. That is important. So, sensitivity level of calculus detection by radiograph is low, but still at times you can see the subgingival calculus in the radiograph. Now, theories on mineralization of calculus. The first theory is mineral precipitation theory. There is local rise in the degree of saturation of calcium and phosphate ions, an increase in the pH of saliva, and then precipitation of calcium phosphate salts by lowering the precipitation constant. The colloidal proteins present in the saliva bind calcium and phosphate ions and maintain a supersaturated solution with respect to calcium phosphate salts. Phosphatase liberated from dental plaque, desquamated epithelial cells or bacteria precipitates calcium phosphate by hydrolyzing organic phosphates in saliva, thus increasing the concentration of free phosphate ions. Now, the seeding agents induce small foci of calcification that enlarge and coalesce to form a calcified mass. This concept has been referred to as the epitactic concept, or more appropriately heterogeneous nucleation. Now, attachment of calculus to the tooth surface. Attachment by means of an organic pellicle on enamel. Then there is mechanical locking into surface irregularities such as resorption lacunae. close adaptation of calculus under surface depression to the gently sloping mounds of the unaltered cementum surface. Then there is penetration of calculus bacteria in cementum. Now, calculus formation, the first is pellicle formation. This is a step of plaque formation, first step. So, first pellicle will be formed, then plaque maturation will be there, then mineralization of this plaque will happen. Within 24 to 72 hours of plaque formation, more and more mineralization centers develop close to the underlying tooth surface. The average time for mineralization by rapid calculus formers is 10 to 12 days, and in case of slow calculus formers, it is 20 days. So, within 14 to 20 days, calculus formation is completed. Now, saliva is the source of mineralization for supragingival calculus, whereas GCF, the serum exudates in the GCF furnish the minerals of subgingival calculus. Calcification begins along the inner surface of the supragingival plaque and in the attached component of subgingival plaque adjacent to the tooth. So, this is diagrammatic representation of calculus formation. Basically, calcium and phosphate will bind to form crystals, and first pellicle formation is there, then plaque maturation, then the calcium and phosphate will bind to form crystals, and that will lead to mineralization and hardening of the calculus. Rate of calculus formation, it is elevated in salivary calcium concentration, and there is elevated bacterial protein and lipid concentration, elevated concentration of protein, urea in submandibular and salivary gland secretions, higher total salivary lipid levels. Now, importance of calculus. Its relation to plaque. Calculus is mineralized plaque because calculus prevention depends upon plaque prevention. Calculus has a rough surface and provides a niche for plaque collection on its surface. Now, relation of calculus to the pocket. Subgingival calculus is always covered with plaque that is in direct contact with the pocket epithelium. Plaque bacteria initiate gingivitis and periodontitis. Now, these are healthy gum, and calculus formation is there, then leads to gingival recession and bone resorption. Now, treatment is by oral prophylaxis. You will do scaling and root planing to remove the calculus. Now, the other iatrogenic factors. These factors iatrogenic factor is an inadvertent adverse effect or complication resulting from medical treatment or advice, including that of psychologists, therapists, pharmacists, nurses, and dentists. Iatrogenic describing the definition of iatrogenic is that it describes a condition that has resulted from treatment as either an unforeseen or inevitable side effect. Now, faults in dental restoration and prosthesis are one of the iatrogenic factors, which are and these are more common cause of gingival inflammation and periodontal destruction. So, one of the factors is faulty prosthesis. Now, coming to the margins of restoration, these provide ideal location for accumulation of plaque, changing the ecological balance of gingival to one that favor the growth of the disease associated organism. Subgingival restorations are plaque retentive areas that are inaccessible to scaling instrument, hence greater chances of severe gingivitis and deeper pockets are there. So, these are the margins of restoration in relation to anterior teeth. Now, contour of restoration and artificial crowns. Over-contoured or improperly contoured restorations, they tend to accumulate plaque as they prevent, the area is not self-cleansable. Now, overhanging dental restoration are also considered to be a contributing factor to gingivitis and possible periodontal destruction. Now, coming to third factor, occlusion. Poorly constructed restorations will cause occlusal disharmonies that may be injurious to supporting normal periodontal tissues. This type of tissue injury is called primary trauma from occlusion. Now, some of the examples of these iatrogenic factors are insertion of high filling, if any high points are there, insertion of prosthesis, replacement that create excessive forces on abutment or antagonist teeth, the drifting movement or extrusion of teeth into spaces created by unreplaced missing teeth, the orthodontic movements of teeth into functionally unacceptable positions. Now coming to materials, in general restorative materials are not by themselves injurious to the periodontal tissues. It is the rough, unpolished surfaces that favor plaque accumulation and contribute to periodontal disease compared to all restorative materials that are available to clinician. GIC restorations and porcelain seems to retain less plaque and thus more acceptable from periodontal point of view. Fluoride constantly leaking from the glass ionomer cement prevents the attachment of bacteria to pellicle, and it also interferes with the metabolism and growth of bacteria. Highly polished surfaces of porcelain inhibits plaque formation and permits its rapid removal. Now designs of your removable partial dentures if the design is not proper, it can lead to increased plaque accumulation, quantitative and qualitative changes by promoting the development of most pathogenic bacteria as they will harbor in that prosthesis. Now periodontal problems associated with orthodontic therapy. Orthodontic therapy may affect the periodontium by favoring plaque retention and also modifying the gingival ecosystem. Direct injury to the gingiva as a result of overextended bands, which may also lead to forceful detachment of gingiva from tooth, causing gingival recession, and it may create excessive or unfavorable force on the supporting tooth structure, causing necrosis of the periodontal ligament and adjacent alveolar bone. Excessive forces also increase the risk of apical root resorption. Now food impaction, it is forceful wedging of food into the periodontium by occlusal forces. Cusps that are tended to forcibly wedge food interproximally are known as plunger cusp. Now according to Hirschfeld, food impaction can occur in the following conditions like uneven occlusal wear, loss of proximal contact, congenital morphologic abnormality of the teeth, improperly constructed restorations, and lateral food impaction. This is for the class today. The topic is completed, and thank you.